Hi, thanks for joining us on GU Oncology Now. It's Chris Wallis joining you today, and I'm really pleased to be joined with Dr. Bossi here to discuss his recently presented work from the PEACE-1 trial, which had an oral presentation at this year's ASCO 2023 meeting. So thank you so much for joining us today, Dr. Bossi.
Thank you to you for inviting me. It's a real pleasure.
So I think, maybe just to lay some groundwork, can you help give our audience a framework for the PEACE-1 trial and understanding where it fits in the landscape of metastatic castrate-sensitive disease?
Yeah, so PEACE-1 was a trial that has been designed some 10 years ago. And this, I guess, it's something very important to remind. At that time, ADT alone was the standard of care for patients presenting with metastatic hormone-sensitive prostate cancer, de novo metastatic prostate cancer. At that time, no information about intensification of the systemic treatment, no information about adding some form of local control of the disease. So this is just to set the scene when the PEACE-1 was designed. And that time with Karim Fizazi, my colleague at Gustave Roussy, we were thinking about two main questions for those patients. First, is ADT alone enough, or should we supplement it by another systemic treatment like abiraterone and prednisone? And second question, should we add some form of local control with radiotherapy? You are well aware, Chris, and soon after, a few years after, we had some results coming from the Stampede group and from the HORAD group in the Netherlands, which both had, of course, ongoing trials which were asking a bit the same question, especially concerning radiotherapy for the primary. And Stampede and HORAD were already presented and published. We presented and published last year, first name Karim Fizazi on Lancet, the results on the first question on PEACE-1, which was the question on abiraterone added to ADT. And we find out that indeed abiraterone may add in terms of overall survival in those patients, especially when they have a huge amount of distant metastasis, as we call high volume disease. And at ASCO, a few weeks ago, I presented the result, the first result concerning the second question, what can radiotherapy add on top of systemic treatment? And this immediately, I'm sure that the colleague listening to us are immediately aware that during these 10 years, the standard of care have been evolving. The landscape of the standard of care has been a very moving one. From ADT, we moved to understanding the importance of docetaxel for those patients. And so during the accrual period of PEACE-1, we introduced some modification of the standard of care, amendment, as we said. At first, docetaxel was permitted, but then we were, in a second amendment, we introduced docetaxel as mandatory for patients and in the standard of care arms. So this made our standard of care evolving from ADT alone to ADT plus docetaxel. So at the end of the day, we have 4 arms. It's a 2x2 trial, which has randomized some 1,300 patients in 4 arms. In the standard of care modified with the adding of docetaxel plus or minus abiraterone, first 2 arms, and then the standard of care plus abiraterone, and the same standard of care plus abiraterone and prostate radiotherapy. For the radiotherapists, which may listen to us today, I just like to remind you that our schedule was a very standard one. When we proposed this trial 10 years ago, no information about hypofractionated radiotherapy. And so we decided for a very standard schedule of 74 gray in the prostate in 37 fraction, 2 gray per fraction. I remind you that, for example, Stampede colleagues were using two kind of different fractionation, both of them in a what we call today in hypofractionated schedules. But on top of this, I have to remind you that we were the only group implementing, from one side, a intensification of the systemic treatment with docetaxel and abiraterone, together with radiotherapy. And this was really, to me and to Karin Fizazi, the most important feature of the trial.
Absolutely. And so as you presented at ASCO, I think there was interesting results, and maybe you can help us understand a little bit the statistics behind it and then the results. But obviously with the interaction between the two treatment approaches, the systemic intensification and the local therapy, there's a question of whether we can pool or we need to look at effects separately. So maybe help us understand how you guys approached that aspect of the trial analysis.
Yeah, this indeed was, if you want, an important question, because at first, when analyzing our data, we wanted to find out if a qualitative interaction between radiotherapy and abiraterone was observed or not. And I remind you, we had two co-primary endpoints of the trial. First, what we call the radiographic progression-free survival. And I have to tell you, of course, that at that time, when we talk about radiographic progression-free survival, we talk about standard radiographic progression-free survival. No new generation imaging was available at that time. And the second co-primary endpoint was overall survival. So we tried to understand if a qualitative interaction was present between radiotherapy and abiraterone for these two co-primary endpoints. And indeed, a qualitative interaction was observed between radiotherapy and abiraterone for the radiographic progression-free survival endpoint. And this meant that each experimental arm was assessed individually. But in terms of overall survival, there was no statistical interaction between radiotherapy and abiraterone. And this meant that the two radiotherapy arms could be pulled together for the final analysis. Right. We needed something like, yeah, I may add, if you want, that we needed something like 300 events for the rPFS, radiographic progression-free survival endpoint, at least for the low volume population of patients, because most of the data presented at ASCO concerned the low volume population of those patients, and some 200 events for the overall survival endpoint.